What if the exhaustion you've been brushing off as stress isn't stress at all? What if millions of women right now are living with conditions their doctors have never once mentioned? Today we reveal 5 silent health problems hiding in plain sight, and number 3 shocks nearly every woman who hears it. Hi, I'm Dr. Zoe Bennett, and before we dive in, I want you to do something for me. I want you to think about the last time you told someone you were exhausted, or your mood felt completely off, or your body just didn't feel like yours anymore. And someone looked at you and said, "You're probably just stressed." How many times has that happened? Because if you're anything like the millions of women I hear from, the answer is more times than you can count. Here's what nobody is telling you. Women are 50% more likely to be misdiagnosed during a heart attack than men. Conditions that affect 1 in 8, 1 in 10, even 1 in 5 women go undetected for years, sometimes decades. And in that time, women are told they're anxious, they're overreacting, they're just getting older. They're handed antidepressants when they need thyroid medication. They're sent home from emergency rooms when they're actively having cardiac events. This is not a rare problem. This is a systemic one. Today we are going to change that. We are going to walk through 5 health conditions that are silently affecting millions of women around the world, in the United States, the United Kingdom, Canada, Australia, across Europe. And we are going to talk about what they are, why they go undetected, what the science actually says, and most importantly, what you can do about it right now. Stay with me all the way through, because condition number 3 is the one that stops women in their tracks every single time. Let's begin. Condition number 1. Hypothyroidism. The master switch. Nobody's checking. I want you to picture a small butterfly-shaped gland sitting at the base of your throat. It weighs less than an ounce, and yet it controls nearly everything. Your metabolism, your energy levels, your mood, your heart rate, your weight, your hair growth, even the way your brain processes information. That gland is your thyroid. And for millions of women, it is quietly failing them while every doctor they see looks the other way. Hypothyroidism, an underactive thyroid, affects approximately 1 in 8 women over the course of their lifetime, according to the American Thyroid Association. 1 in 8. That means right now, statistically, if you're watching this with a group of friends, at least one of you has this condition, maybe more. And here's the part that should make you angry. The average time from symptom onset to diagnosis is somewhere between 5 and 10 years. 5 to 10 years of a woman feeling progressively worse, going to doctor after doctor, and being told her labs look fine. Why does this happen? Because the symptoms of hypothyroidism are devastatingly ordinary. Fatigue, weight gain, brain fog, depression, dry skin, feeling cold all the time, hair thinning, constipation, low mood. These are not dramatic, alarming symptoms that send you rushing to the ER. These are the symptoms that get dismissed with a, "Well, you're a busy woman," or "Have you tried exercising more?" They are the symptoms that get quietly rebranded as anxiety, perimenopause, or simply the reality of modern life. Here's what's actually happening inside the body. Your thyroid produces hormones, T3 and T4 artery, that regulate cellular metabolism throughout your entire body. When the thyroid underperforms, your pituitary gland sends out a hormone called TSH, thyroid-stimulating hormone, essentially screaming at your thyroid to work harder. A standard blood test measures TSH, and if it falls within the normal range, most doctors stop there. But here's the critical problem. The TSH reference range is broad and contested, and many women suffer genuine symptoms at levels that laboratories classify as technically normal. Without testing free T3, free T4, and crucially, thyroid antibodies, you are only getting half the picture. And that brings us to one of the most important things I'll tell you today. The most common cause of hypothyroidism in women is not iodine deficiency or aging. It is an autoimmune condition called Hashimoto's thyroiditis, where your own immune system attacks your thyroid gland. Hashimoto's can be present and actively destroying thyroid tissue for years before TSH levels shift noticeably. If your doctor isn't testing for thyroid antibodies, specifically TPO and TGAB antibodies, Hashimoto's will be completely invisible on a standard panel. You can go years with an immune system quietly dismantling your thyroid, feeling progressively worse, while every blood test tells you that you're perfectly fine. What do? The next time you're at your doctor, you ask, specifically and clearly, for a full thyroid panel. TSH, free T3, free T4, and thyroid antibodies. If your doctor resists, you explain that you've been experiencing fatigue, brain fog, and weight changes that are affecting your quality of life, and you would like a comprehensive evaluation. Nutrition matters too. Selenium, found in Brazil nuts and eggs, is essential for converting T4 into the active T3 form your cells actually use. Iodine from seafood and dairy supports hormone production, and sleep, genuinely restorative sleep, is non-negotiable for thyroid health. If you are diagnosed, know this: treatment with levothyroxine, a synthetic thyroid hormone, is one of the most well-tolerated, life-changing medications in medicine. Women describe it as getting their life back. You don't have to keep suffering. You just need someone to look in the right direction. Now, if that surprised you, wait until you hear about condition number 2. It affects the very organ that keeps you alive, and most women have absolutely no idea they're at risk. Condition number 2, cardiovascular disease, the killer we've been taught to ignore. Let me ask you something. When you think about the biggest health threat facing women today, what comes to mind? If you said breast cancer, you are not alone. Studies from the Cleveland Clinic show that approximately 80% of women believe breast cancer is their number 1 killer. And here's the heartbreaking truth: they are wrong. Heart disease kills more women every single year than all cancers combined. It is the number 1 cause of death in women globally, according to the World Health Organization. And because we have collectively failed to communicate this, women are dying from a condition they didn't know they needed to fear. The reason cardiovascular disease is so silent in women comes down to one fundamental problem. For most of modern medical history, heart disease was studied almost exclusively in men. The symptoms we learned to recognize: the classic crushing chest pain radiating down the left arm, the Hollywood heart attack, that is largely a male presentation. Women's hearts have a different story to tell, and for too long, no one was listening. Women having heart attacks more commonly experience jaw pain, nausea, extreme and sudden fatigue, back pain, shortness of breath, or something that feels uncomfortably like indigestion. These symptoms are vague, they are easy to dismiss, and they are routinely dismissed. Women presenting to emergency departments with cardiac symptoms wait significantly longer to be seen than men, are less likely to receive an ECG promptly, and are more likely to be told their symptoms are anxiety-related. One British study found that women were 50% more likely to be misdiagnosed after a heart attack, 50% in 2024. There's also a condition called EMINOCA, myocardial infarction with non-obstructive coronary arteries, which describes heart attacks that occur without the large arterial blockages typically associated with cardiac events. MINOCA predominantly affects women, is frequently missed on standard cardiac imaging, and remains dramatically underdiscussed in both clinical and public health conversations. You can have a heart attack, your angiogram can look relatively clear, and you can still be sent home without answers. This is why knowing your full cardiovascular risk profile is so much more important than knowing your cholesterol number alone. Before menopause, estrogen provides women with a degree of cardiovascular protection. It helps maintain flexible blood vessels, supports healthy cholesterol ratios, and reduces inflammation. But after menopause, that protection diminishes rapidly, and a woman's cardiac risk begins to approach that of a man's within just a few years. The decade following menopause is a critical window, and most women don't know they're in it. What should you do right now? Know your numbers, not just total cholesterol, but LDL, HDL, triglycerides, blood pressure, fasting blood sugar, and your body's inflammatory status. Ask your doctor about a high-sensitivity C-reactive protein test, or HSCRP. This marker of systemic inflammation is actually a stronger predictor of cardiovascular events in women than standard cholesterol measurements, yet it's rarely included in routine panels. If you have a strong family history of heart disease, don't wait for symptoms. Ask about early screening. Lifestyle is powerful here. The Mediterranean diet, rich in olive oil, oily fish, legumes, vegetables, nuts, and whole grains, has more robust cardiovascular evidence behind it than almost any other dietary pattern. 150 minutes of moderate aerobic exercise per week, quality sleep, and active stress management are not optional lifestyle luxuries. They are cardiac medicine. And if you are ever in an emergency setting with symptoms you cannot explain, jaw pain, extreme fatigue, nausea, shortness of breath, you ask for an ECG and you do not leave until someone takes you seriously. Okay, we're halfway through, and now we're at condition number 3. This is the one where I always see the comments flood in, because it's the condition most women have lived with for years without ever knowing it had a name. Condition number 3, PCOS, the condition, hidden in plain sight. Polycystic ovary syndrome, PCOS, affects approximately 1 in 10 women of reproductive age worldwide, according to the World Health Organization. That translates to roughly 200 million women globally. It is one of the most common hormonal conditions in existence, and yet, on average, a woman visits 3 or more healthcare providers over 2 to 3 years before receiving a correct diagnosis. How is that possible? Because PCOS is a masterful impersonator. Its symptoms scatter across multiple body systems in a way that sends women to different specialists for each individual complaint, and no one ever steps back to see the full picture. You go to the dermatologist for your acne. You go to the dietitian for your unexplained weight gain. You go to the therapist for your anxiety and low mood. You go to the gynecologist for your irregular periods and are told to go on the pill. Nobody connects the dots. Nobody says, wait, these aren't separate problems. These are all signals from the same underlying hormonal disruption. Here's what's happening physiologically. Women with PCOS typically have elevated androgen levels, male sex hormones, including testosterone, that produce symptoms like acne, excess facial or body hair, and hair thinning on the scalp. Their ovaries may develop multiple small follicles that don't fully mature, disrupting or completely preventing ovulation. And critically, in approximately 70% of cases, there is significant insulin resistance. This means the body's cells don't respond normally to insulin, so the pancreas produces more and more of it. Elevated insulin, in turn, signals the ovaries to produce even more androgens, creating a self-reinforcing hormonal cycle that drives symptoms from every direction simultaneously. The long-term implications of unmanaged PCOS go far beyond irregular periods and acne. Women with untreated insulin resistance have a significantly elevated risk of developing type 2 diabetes. Some studies suggest up to 7 times the risk of women without PCOS. The chronic inflammation and metabolic dysfunction associated with PCOS also raises cardiovascular risk, and the hormonal imbalance creates a higher lifetime risk of endometrial cancer due to irregular or absent ovulation. Additionally, anxiety and depression are significantly more prevalent in women with PCOS, and for good reason. Because living in a body that feels out of control, being dismissed by doctors, and struggling with symptoms that affect your appearance and fertility takes a profound psychological toll. One myth I need to dismantle right now. The pill does not treat PCOS. I want to be very clear about this because it is one of the most pervasive and damaging misconceptions in women's health. Oral contraceptives can regulate the menstrual cycle and reduce androgen-related symptoms by suppressing the hormonal fluctuations of PCOS, but they do not address insulin resistance. They do not treat the underlying metabolic dysfunction. When a woman comes off the pill, her symptoms return, often worse, because the root cause was never addressed. She was managed, not treated. What does evidence-based management look like? A low glycemic diet, one that avoids blood sugar spikes by prioritizing whole grains, legumes, vegetables, lean protein, and healthy fats, has strong research support for reducing insulin resistance and androgen levels in PCOS. Resistance training specifically has shown remarkable benefits for improving insulin sensitivity in ways that cardio alone does not replicate. Inositol AC, particularly the combination of myo-inositol and D-chiroinositol, has an expanding and genuinely promising research base for improving ovulation, insulin sensitivity, and hormonal balance. And for women with confirmed insulin resistance, metformin remains a well-evidenced pharmaceutical option. Ask your doctor for a full hormonal and metabolic workup: testosterone, LH, FSH, DHEA-S, fasting insulin, fasting glucose, and an ultrasound. And if you're told that your periods being irregular is just normal for some women, push back. It's not. It's a signal worth investigating. Now, condition number 4 is one that genuinely shocks people because it's been inside medical textbooks for over a century, yet most women hear about it for the first time from a friend, not a doctor. Condition number 4, endometriosis, a century of being dismissed. 190 million women worldwide are living with endometriosis, according to the World Health Organization's 2023 data. 190 million. It is not a rare disease. It is not an unusual condition. It is one of the most prevalent chronic diseases affecting women of reproductive age on the planet. And the average time from symptom onset to diagnosis is 7 to 10 years. 7 to 10 years of pain. 7 to 10 years of being told that periods are supposed to hurt. 7 to 10 years of a disease progressing, potentially causing irreversible damage to fertility and quality of life, while women are handed ibuprofen and sent home. Endometriosis occurs when tissue that behaves similarly to the lining of the uterus grows outside the uterus, on the ovaries, the fallopian tubes, the bowel, the bladder, sometimes even further afield. Each month, just like the uterine lining, this tissue responds to hormonal fluctuations. It thickens, it breaks down. But unlike menstrual blood, it has nowhere to go. This causes internal inflammation, the formation of scar tissue and adhesions, and in many cases, the fusing together of pelvic organs. The symptoms range from debilitating pelvic pain and agonizing periods, to pain during sex, pain with bowel movements or urination, chronic fatigue, and infertility. But because the anchor symptom is painful periods, and because girls and women have been culturally conditioned for generations to accept menstrual pain as an ordinary part of womanhood, the alarm bells that should send someone urgently to a specialist are instead normalized into silence. Women with endometriosis often describe calling in sick from work, missing school, canceling plans, curling up on bathroom floors during their periods, for years, before anyone took them seriously. There is no blood test for endometriosis. A standard ultrasound will miss the majority of lesions. The only definitive diagnostic method is laparoscopy, a surgical procedure which creates an obvious and significant barrier to diagnosis. But here's what's important to understand. You don't need a diagnosis in hand to begin advocating for specialist care. If you have painful periods that disrupt your life, pain during sex, bowel or bladder symptoms around your cycle, or unexplained chronic pelvic pain, these are clinical red flags that warrant a referral to a gynecologist with specific expertise in endometriosis. The gold standard treatment is excision surgery, the complete surgical removal of endometrial lesions, performed by a highly skilled specialist. Ablation, which burns the surface of lesions rather than removing them, has significantly higher recurrence rates and is considered inferior for most cases. Hormonal therapies can suppress symptoms but do not eliminate the disease. Anti-inflammatory diets, pelvic floor physiotherapy, and pain management strategies form an essential part of holistic care. If you want support and evidence-based information, organizations like Endometriosis UK, the Endometriosis Foundation of America, and Jean Hals in Australia are extraordinary resources. And please, if you have been told that your pain is normal, that you're being dramatic, that all women feel this way, that is not medicine. That is dismissal. Pain that interrupts your life is never normal, and you deserve to be heard. Now let's talk about condition number 5. This one is perhaps the most underestimated of all, because it can be invisible even on medical tests. It affects every woman eventually, yet it remains one of the most underprepared for transitions in a woman's entire life. Condition number 5, perimenopause, the transition. Nobody prepares you for here is a fact that surprises nearly every woman who hears it. Perimenopause, the transitional hormonal phase leading up to menopause, can begin as early as the late 30s or early 40s. Not the late 40s, not practically 50, the late 30s. And it can last anywhere from 4 to 12 years. This means that a woman could be navigating a profound whole-body hormonal shift for over a decade before she ever reaches clinical menopause. And for most of that time, she may have absolutely no idea that's what's happening to her. Why? Because we have collectively reduced perimenopause to hot flashes and mood swings. And in doing so, we have made invisible one of the most significant physiological transitions of a woman's life. The reality of perimenopause is far broader and far more impactful than this reductive picture suggests. Estrogen, progesterone, and testosterone don't decline in a smooth, predictable line. They fluctuate wildly, surging and crashing, before eventually falling. And because estrogen receptors exist throughout the entire body, in the brain, the heart, the bones, the gut, the skin, its erratic decline produces symptoms across virtually every organ system. Brain fog, memory lapses, difficulty concentrating, anxiety and depression appearing seemingly from nowhere in women who have never struggled with mental health before. Sleep disruption, not just trouble falling asleep, but disrupted sleep architecture, reduced REM sleep, early morning waking, joint pain, heart palpitations, changes in body composition, particularly abdominal weight gain, vaginal dryness and changes in libido, skin and hair changes, and yes, eventually, hot flashes. These are not separate, unrelated complaints. These are the fingerprints of declining estrogen on a body that depended on it. Here's where the diagnostic failure happens. Hormone levels in perimenopause are not consistently low. They are erratically fluctuating. A single blood test taken on the wrong day can look completely normal. Many women visit their doctors, describe textbook perimenopausal symptoms, receive hormone testing, are told everything is fine, and are sent away with antidepressants or sleeping tablets that do not address the root cause. The Menopause Charity Well-Being of Women found that 1 in 4 women in the UK waited more than a year to receive a diagnosis or appropriate support for perimenopausal symptoms. 1 in 4. The science here is critical and empowering. Estrogen is neuroprotective. It helps maintain brain structure and function, reduces inflammation in the brain, and supports memory consolidation. Its decline is why cognitive symptoms are so common and so distressing. Bone density begins accelerating its decline during perimenopause, years before menopause, which means the window for prevention is earlier than most women realize. And the cardiovascular protection estrogen provides starts diminishing in this phase, making lifestyle intervention during perimenopause, not after the most impactful time to act. The conversation around hormone replacement therapy has been clouded for over 2 decades by a flawed and widely misrepresented 2002 study from the Women's Health Initiative that overstated risks and caused millions of women to avoid or be denied treatment that could have substantially improved their quality and longevity of life. Current evidence, including major reanalyses and updated guidelines from both the British Menopause Society and the Menopause Society in the United States, confirms that for women under 60 or within 10 years of menopause onset, without specific contraindications, the benefits of HRTEIs for symptom relief, bone protection, cardiovascular health, and cognitive well-being substantially outweigh the risks for the majority of women. This is a conversation worth having with a menopause specialist physician, not a dismissive 5-minute GP appointment. What can you do right now? Start tracking your symptoms using a validated tool like the Green Climacteric Scale or the Menopause Rating Scale. These give your doctor objective data rather than a vague sense that you just feel off. Ask for a hormonal panel including FSH, LH, estradiol, testosterone, and SHBG, and ask for it to be repeated if your first result seems inconsistent with your symptoms. Prioritize weight-bearing exercise, walking, strength training, yoga for bone protection. Increase your omega-3 intake. Make magnesium a non-negotiable part of your supplement routine for sleep and mood. And if you are told your symptoms are just stress or part of getting older, know that you deserve more than that answer. 5 conditions, millions of women, and an extraordinary, unjustifiable gap between the women who are suffering and the answers they deserve. So let's bring it all together. Hypothyroidism asks you to demand a full thyroid panel, not just TSH, but the complete picture. Cardiovascular disease asks you to see your heart as your most vital feminist issue, to know your real risk profile, and to never allow your cardiac symptoms to be reframed as anxiety. PCOS asks you to refuse isolated treatment for scattered symptoms and demand someone look at you as a whole, hormonal picture. Endometriosis asks you to reject the normalization of pain and fight for specialist care. And perimenopause asks you to start the conversation years earlier than you thought necessary, and to walk into that conversation armed with knowledge. The thread that runs through all 5 of these conditions is the same thread that has run through women's health care for generations: the tendency to dismiss, to delay, to minimize, and to under-investigate. But here is what I know with complete certainty. When women have information, they become unstoppable advocates for themselves. They ask better questions. They push back harder. They find the right doctors. They get the right diagnoses. And they get their lives back. Your symptoms are real. Your pain is real. Your exhaustion is real. And you deserve a healthcare system that treats it that way. Share this video with the women in your life. Your mother, your daughter, your best friend, your colleague who's been just tired for 3 years. Because the first step toward getting answers is knowing the right questions to ask. And now, you do.